Hello, I'm Kimberly Hughes, and today we're going to discuss the processes of labor and birth. The factors that affect the process of labor can be broken down into what we call the 5 P's: the passenger or the fetus and placenta, the passageway, the birth canal, the powers or the contractions, the position of the mother, and the psychologic response of the mother. We'll start with the passenger, and the items that we have to consider about the passenger are the size of the fetal head, the fetal presentation, the fetal position, the fetal lie, and the fetal attitude. The skull of the fetal head is composed of 2 frontal bones, 2 parietal bones, 2 temporal bones, and 1 occipital bone. In the fetal skull, these bones are not fused as they are in adults, and the spaces between them are called sutures. The fetal head also has fontanelles where the sutures intersect. The 2 most important fontanelles are the anterior and posterior. They're the main landmarks used by OB providers to tell which way the baby is facing in the pelvis. The sutures in the fontanelles allow the head to be flexible so it can fit through the mom's pelvis. This picture shows you roughly the diameter of the fetal head at term. As you can see, the smallest value is the subooccipital pragmatic diameter. If the baby's head is flexed, this is the diameter of the skull as it enters the pelvis. If the head is not flexed, the diameter of the skull as it enters the pelvis will be the occipital frontal diameter, which is roughly about 12 centimeters. If the head is extended, then the diameter of the skull as it enters the pelvis is the occipital mental diameter, which is the largest at 13.5 centimeters. So as you can see, flexion or extension of the head can determine whether or not it'll fit through the pelvis. This picture also shows you how the diameter of the head changes depending on whether it's flexed or extended. The fetal presentation refers to the part of the fetus that enters the pelvis first. Most common is head first or vertex, but there are other options. There is a shoulder presentation, as you see in the lower right, or breech presentation. Breech can be broken down into 3 groups. The baby can either be frank breech, as it shows in the upper left, footling breech, as it shows in the upper right, or complete breech, as it shows in the lower left. The most common presentation is vertex. Babies can further be categorized into positions. Position is the relationship of the presenting part, or in this case the head, to the maternal pelvis. Position is determined by comparing where the occipital bone is in relationship to one of the 4 quadrants of the mom's pelvis. Position can help you determine which way the baby is facing by feeling for the position of the fetal skull bones, sutures, and fontanelles. If the occiput is in the upper right of the maternal pelvis, the baby is in the right occipital anterior position, like the one you see the baby in the lower left of the screen. So in these babies, we're going to determine which baby is facing what way. You know that the anterior fontanelle is the big one in the front, and the occipital bone is in the back of the skull. So, which way is baby A facing? As you can see, the anterior fontanelle, which is found in the front, is closest to the back of the mom's left hip. Therefore, the occiput that's in the back of the head is pointing to the front of the mom's right hip. So the baby would be in the right occipital anterior position. How about baby B? So once again, the large anterior fontanelle is closest to the front aspect of mom's left hip. Therefore, the occiput, or the back of the head, is closest to the right posterior aspect of mom's pelvis. So the baby is in the right occipital posterior position. Now we're going to discuss fetal lie. The fetal lie is the relationship of the fetal spine to the maternal spine, and the two primary are longitudinal, or up and down, or transverse. Longitudinal can either be vertex with the head down, as depicted here, or breech with the butt down. So here's our first question. If the fetal head is determined to be presenting in a position of complete extension, the nurse should anticipate a precipitous labor and delivery, prolonged labor and possible cesarean delivery, a normal labor and a spontaneous vaginal delivery, or a forceps-assisted vaginal delivery. The answer is 2. The normal attitude of the fetal head is one of moderate flexion. Changes in the fetal attitude, particularly the position of the head, present larger diameters to the maternal pelvis, which contribute to a prolonged and difficult labor and increases the likelihood of cesarean delivery. Fetal attitude is the relationship of the fetal parts to each other. In most cases, the fetus will assume a position depicted in diagram A. The back is rounded, the legs are flexed up against the abdomen, the arms are folded, and the chin is tucked onto the chest. This is described as general flexion. Deviations from this posture, as depicted in diagram B, C, and D, will make childbirth more difficult. If the baby is correctly situated, the baby will descend and you'll see changes in the fetal station. Fetal station is defined as the relationship of the presenting part to the maternal ischial spines of the pelvis. Think of a number line that you learned about when you were in middle school math class. 0 station means that the presenting part is right at the ischial spines, as shown here, but the presenting part may also be above or below. Engagement means that the largest portion of the fetal head has passed through the pelvic inlet and into the true pelvis. This usually corresponds with 0 station. In order to determine the location of the ischial spines and the pelvic inlet, you have to be familiar with maternal pelvis, which is where we're going to now. The maternal pelvis is the passageway, which contains the bony pelvis, the cervix, the pelvic floor muscles, the vagina, and the introitus. Question 2. The nurse notes on the antepartal history that the client has an android pelvis and recognizes an increased risk for prolonged labor, occiput posterior position, precipitous delivery, or developing postpartum complications. The answer is 1. An android pelvic structure is narrow in both the anterior-posterior diameter and the lateral diameters and can cause a prolonged labor with a large fetus or a malpositioned fetus. There are 4 general pelvic types in women. The gynecoid pelvis is the most common. Over 50% of women have this type of pelvis, which is good because it's also the most roomy and allows for a baby to pass relatively easily. The other pelvic types, android, anthropoid, or platypoid, are less common and, depending on the size of the baby, may not allow the mom to deliver vaginally. The bony pelvis is formed by the fusion of the ilium, ischium, pubis, and sacral bones. The bony pelvis is separated into 2 parts, the true pelvis and the false pelvis, by what is known as the pelvic brim. The false pelvis is the part we can feel when we put our hands on our hips. This part of the pelvis has nothing to do with childbirth. Women can have very wide hips, but their true pelvis may still not be big enough for a baby to pass through. The true pelvis, the part that is involved in childbirth, is further separated into three planes: the inlet, the mid-pelvis, and the outlet. The diameter of these planes will determine if vaginal delivery is possible. The pelvic outlet is where the ischial spines are located and is the smallest of the three planes. Typically, if a baby can make it past the ischial spines, then vaginal delivery is expected. The soft tissues of the passageway are the lower uterine segment, the cervix, and the pelvic floor muscles, the vaginal canal, and the vaginal introitus. The upper part of the uterus is thick and muscular. This is what contracts and pushes the baby down. The lower uterine segment is thin-walled and passive and distends easily as the baby moves down. There's a physiologic retraction ring that separates the two segments, and at times this ring can have a band that constricts it, which may slow down progress. This is not common, and usually if a baby can pass through the birth canal, if the baby can't pass through the birth canal, it's because of the bones of the pelvis. But just remember that there are other reasons. Another part of the passageway that the baby has to move through is the cervix. As the baby descends, the cervix softens, thins, and opens. The muscles of the pelvic floor and the vaginal canal stretch and help to rotate the baby, which then emerges from the vaginal introitus. You'll see a video on this towards the end of the presentation. As we previously stated, the upper uterine segment is thick and muscular and contracts to move the baby through the pelvis and up to the pelvic floor. This is the primary power of labor. Now, once the baby reaches the pelvic floor, the Ferguson reflex takes over, which causes the mom to want to push or bear down. This reflex may be diminished in women that have epidurals, and this is usually called the secondary powers. Position is the fourth P. And we're not talking about the position of the baby as we have done previously. We're talking about the position of the mother. Frequent position changes by the mother does a couple of things. For starters, it keeps the woman comfortable. Laying in one spot for hours and hours is not natural. Even if you're not pregnant, it reduces circulation and sets you up for problems. If you know you're laying in one position, after a while you'll get uncomfortable and want to move. This is a protective mechanism to ensure adequate circulation to all your body parts. If a mom has an epidural and is in labor, she may not feel those sensations that prompt you to move because the nerves that transmit them are dulled. This doesn't mean she doesn't need to move, it just means that she can't feel anything. So you have to tell her that she needs to rotate, and you probably need to help her move into a new position every hour or so. Movement also allows the baby to turn better and move in order to facilitate birth. Remaining stationary can hinder the progression of labor. These are just a few of the maternal positions that are both comfortable and may improve and promote labor progress. The psychological responses of the patient depend on the phase of labor. In latent labor, patients are uncomfortable, but pain is fairly controlled. They're usually excited, they're alert, and able to follow directions. They're open to instructions, and thoughts are focused around themselves and their baby. In the active phase of labor, and we'll get into the phases in a little bit, the patient is more serious. The pain has increased, and therefore they're a little bit more apprehensive and need more encouragement. They desire companionship, but their attention is turned inward, so they might not talk very much. And they might have difficulty following instructions. In transition, this is when the pain is the worst, and they are doubtful of their ability to continue. This is when they need you the most, to cheer them on and tell them what a good job they're doing. They don't communicate well, but this is when they're in most need of support. The pain is not just in their abdomen, but in their back and their hips. They may be irritable, and they may voice it. They may be writhing with contractions. They may hyperventilate. They may even become nauseous and vomit, or break out into a sweat. So the previous slide provided a general view of the physiologic response to patients in labor, but we must keep in mind that every woman is different. We're all a byproduct of our environment and culture, and life experience plays a big part. Birth practices can be very different from one culture to another, and a woman who has suffered something like a sexual assault may react very different in labor, and a woman who has had other children may act very different from a mom who's having her first. As the care provider giving care, emotional support is very important. Women who feel well supported are more relaxed in labor. They use less pain meds and more likely to have a spontaneous vaginal delivery than those who aren't supported. The catecholamines that are released when you're under stress initiate your fight or flight actions. They also shunt blood away from your vital organs, of which the uterus is one. The uterus is not a vital organ. You do not need it to live. And a woman who's relaxed has better uterine circulation and therefore a more productive contraction pattern and a better chance of a successful delivery. And don't forget about the partner. You more than likely won't be able to be in the mother's room the whole time she's in labor. You'll probably have other patients that you have to see about. And when you step away, the partner is the one who's assuming that supportive role for the mom. Partners may also feel fearful and apprehensive and out of control. They may need support and guidance so that they can better support the mom. So don't push the partner out of the way when you come to the room. Include him or her so that they may continue to provide support in your absence. What can we as nurses do to support a laboring mom emotionally? This slide lists some interventions. This is in no way an exhaustive list, it's just a start. But what do you think it means to be non-judgmental? What do you think it means to be an advocate? And how can we work to protect her privacy on a busy labor and delivery unit with multiple interns, residents, and students and nurses' aides running around? Well, if you just keep in mind how you would like to be treated, all of you should have come from health assessment, so all of you have had the opportunity to lay in a bed and be poked and prodded by someone else. So you've had a little bit of that experience. So just try to remember how you would want to be treated if you were in that same position. And if you keep that in mind, then 9 times out of 10, you'll always make the right decision. We discussed the 5 P's that can affect how labor progresses, and now we're going to discuss some signs that you may see in a mom who's going into labor or progressing in her labor. Okay, here's question 3. A pregnant woman at 38 weeks gestation says she wants to know if any signs indicate that labor is getting close to starting. The nurse informs the woman that this is a sign that labor may begin soon. 1, a weight gain of 1.5 to 2 kilograms. 2, an increase in fundal height. 3, urinary retention. Or 4, a surge of energy. So I know you guys all got this right. So the answer is 4. Signs preceding labor include lightning or the baby dropping in the pelvis, return of urinary frequency, so she's going to the bathroom more, not less, backache, surge of energy, increased vaginal discharge, or Braxton Hicks contractions. She can have all of those, or she can have maybe only 1 or 2 of those. But those are signs that something is beginning. In first-time moms, the baby may drop a couple of weeks prior to labor starting. She will then feel as though she can breathe better, but she's going to be in the bathroom all the time because the baby will be lower in her pelvis and pressing on her bladder. In moms who have had children before, the baby may not drop until the contractions become strong and regular. Bloody show may be present as the pelvic congestion increases and little microscopic blood vessels break and ooze. This is usually caused by the stretching and softening of the cervix. We really don't know what causes labor. No one can pinpoint what brings labor on. If we knew that, we would know how to stop it if it comes too early. It's more than likely a combination of things. But one thing that we do know, true labor is described as strong regular contractions that result in cervical dilation. So we don't know why women go into labor, but we do know what constitutes true labor versus, false labor. So question 4. During the second stage of labor, nursing action should include withholding oral fluids, positioning the woman comfortably for birth, administering analgesic, or conducting an APGAR assessment. Well, of course, conducting an APGAR assessment is not right. We don't have a baby yet. So the answer is 2. The second stage extends from complete cervical dilation to delivery of the newborn. Any position of comfort may be selected by the woman at this time. Ice chips and clear fluids to prevent dehydration are usually allowed. Analgesics are administered in the first stage of labor, usually during the active phase when she's in the most pain. And respiratory depression at birth or fetal sedation is not usually an issue at this point. An APGAR assessment, as I said, would not be conducted until after delivery of the newborn. So what we want to do is get mom ready for delivery. So the stages of labor. The first stage of labor is from the onset of regular contractions to full dilation of the cervix. This is the longest stage, and it's divided into 3 phases. The first phase is the latent phase. During the latent phase, the cervix effaces and contractions become more regular and closer together, and dilation progresses very slowly. In the second phase of the active stage, contractions are closer together, strong and regular, and the cervix dilates much more rapidly. This is usually when we admit women to the hospital. The latent phase, especially in the first time mom, can sometimes go on for a couple of days, and we wouldn't want to keep them in the hospital that long, and they wouldn't want to be there that long. But once they get into the active phase, the contractions speed up and everything goes a little quicker, and we can expect a vaginal delivery after several hours. The third phase is transition, and this is the phase right before complete dilation. Contractions are frequent, regular, and strong. This is when the mom is going to be in the most pain and require the most support. But it's also the shortest. And once the mom gets to complete dilation, then she moves into the second stage. And this stage goes from complete dilation to delivery of the baby. This also has a latent and an active phase. In the latent phase, the baby continues to descend through the birth canal and rotate, but mom may or may not have the urge to push right now. The active phase of the second stage is when the baby has reached the pelvic floor and the Ferguson reflex is activated. At this point, the mother will have an urge to bear down or push. The third stage is from the birth of the baby and ends with the delivery of the placenta. This stage is very short. It may only be a few contractions. And the fourth stage is the recovery, where hemostasis is reestablished. This is an important period to observe for complications such as postpartum hemorrhage. So question 5. The nurse determines that a vaginal delivery of vertex presentation is more likely to occur if the passenger, or the fetus, adapts to the passageway or the pelvis in which sequence of movements. Your options are flexion, internal rotation, external rotation, and extension, or extension, flexion, descent, external rotation, or descent, internal rotation, extension, external rotation, or number 4, internal rotation, descent, flexion, and extension. So the answer is 3, descent, internal rotation, extension, and external rotation. The cardinal movements of the fetus occur in that order, starting with engagement, moving all all through the internal rotation, descent, flexion, and extension, and then last, expulsion of the baby. These movements represent the normal adaptation of the fetus to the maternal pelvis and facilitate vaginal birth. It's a very tight fit for the baby's head through mom's pelvis, and they have to kind of move and contort themselves around in order to make it through. The movement of the pelvis that the fetus has to go through in order to navigate the mom's pelvis are called the 7 cardinal movements of labor. The fetal presenting part is large in comparison to the mom's pelvis, which has lots of contours and changes in diameter from inlet to outlet. In order for vaginal birth to occur, the fetus must move and turn in certain ways to navigate the birth canal. These maneuvers that the fetus has to make are termed the mechanisms of labor, or the 7 cardinal movements. And once again, they are engagement, descent, flexion, internal rotation, external rotation, or extension, and then external rotation, and finally expulsion. The first movement, as I said, is engagement. The head is usually engaged in a synclitic position, which means it's parallel with the anterior-posterior plane of the pelvis, as is shown in diagram B. This position will allow the head to descend into the pelvis. If the head is asynclitic, it may not be able to descend depending on the size of the head in comparison to the pelvis. So that's with diagram A or diagram C. Engagement and descent are shown in diagram A. The head moves into the true pelvis with the pressure of the contractions. The degree of descent is measured by the station, which we've already discussed. Flexion, as depicted in the B diagram, is when the baby curls up, the head tucks in, the chin goes down on the chest, and this permits the head to have the smallest diameter possible. The baby must enter the pelvis in the transverse position because the inlet is widest from side to side, the inlet of the pelvis. As the baby moves down, the outlet is widest from front to back, so the baby must rotate. Internal rotation is when the baby rotates to the occiput anterior position as shown in diagram C to fit through the pelvic outlet. As the head exits the pelvis, the chin must stay tucked to allow the fetal head to fit under the pubic bone. Extension, or the 4th cardinal movement, happens after the head slides under the pubic bone. The neck must extend, as shown in diagram D, to allow the head to exit the vaginal canal. After the head is out, the shoulders must fit through the pelvic outlet, which, once again, is biggest from front to back. So the baby must turn sideways, which is termed external rotation, as depicted by diagram E and F. Expulsion, the final cardinal movement, is the birth of the rest of the baby's body. So I'm not sure if you all will be able to view this video, but I will leave the link in, and if the hyperlink doesn't work, then you can maybe just type it into your internet browser. It really helps to put everything together for you so it makes sense, and it's very short. I highly recommend it. So physiologic adaptations to labor, this is fetal and maternal. They both have to go through some changes when they start the labor process. We'll start with the fetus. The progressive contractions of labor affect the fetal heart rate and circulation. The fetal heart rate may fluctuate during labor as a compensatory mechanism to handle the stress of the contractions. When a contraction happens, blood flow through the uterus is decreased because the muscles are contracted around those vessels. In an attempt to maintain homeostasis, the fetal heart rate may decrease to lessen the metabolic requirement, and then go back to normal when oxygenated blood is readily available again. The fetus is built to handle this sort of stress, but the care provider needs to pay attention to the frequency and the duration of the contractions because the fetus only gets a break in between, so his baby's resources aren't depleted. Certain changes occur during labor that allow the fetus to initiate respirations after birth. As the baby is squeezed through the birth canal and the chest and abdomen are compressed, the fetal lung fluid is squeezed out. The fetal O2 levels decrease, CO2 increases, and arterial pH decreases. All of that is to stimulate the brain stem to start breathing. Without going through these changes, it's a little bit difficult for babies to adapt to life outside the uterus. The mother also goes through some physiologic changes during labor. As a woman progresses through the stages of labor, various body systems have to adapt, causing her to exhibit both objective and some subjective symptoms. Last but not least, we're going to cover some physiologic adaptations to labor that mom has to go through. And here are the main systems involved: cardiovascular, respiratory, renal, integumentary, musculoskeletal, neurological, gastrointestinal. An example of gastrointestinal is mom's absorption of food and gastric emptying slow down or significantly decrease, and she might experience some nausea and vomiting. As far as cardiovascular, with each uterine contraction, blood is pushed out of her uterus and back into her circulation, which increases her cardiac output slightly, which might increase her blood pressure and decrease her pulse. As far as respiratory, with pain, her respiratory rate might increase. As far as endocrine, the hormones that keep her pregnant, such as progesterone, decrease, and things like prostaglandin, which soften the cervix, increase. So, in conclusion, we have discussed the 5 factors that can affect the progression of labor and birth. We've also talked about how we recognize that labor is starting and progressing, and we've talked about some changes that we might see in a mom or baby that is going into labor. As nurses, if we know the processes of labor and birth, we can recognize when things start to veer off course. Then we can work to get them back on course to correct the problem. So in the end, this is what we end up with, hopefully a healthy, happy baby and a healthy, happy mom. Thank you.